Hello, welcome to our live webinar titled MDS and Secondary AML 2019 ASH Updates. Thank you for joining us today. My name is Lee Clark and I will be moderating the presentation. As we get started, we recognize the generous support of Agios, Genentech, Jazz Pharmaceuticals, along with our patients, families, and caregivers for their support for this webinar today. At this time, I would like to let you know about a change in our educational programming. In light of the COVID-19 concerns, the Aplastic Anemia and MDS International Foundation will be hosting our patient and family conferences virtually. This means you will be able to participate in the conferences from the comfort and safety of your home. We understand how important it is to provide answers, support, and hope. We are committed to continuing to provide these important educational opportunities. Our first virtual conference will occur on Saturday, April the 25th. For more information about this conference and to register, please visit our website, aamds.org. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you are finished typing, just hit enter. We will do our best to get to all of your questions today. When asking questions, I do ask that you do 2 things for us to help us manage incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Amer Zeidan, who is an associate professor of medicine. He specializes in the management of MDS and acute myeloid leukemia. He is nationally and internationally recognized expert in the clinical management of myeloid malignancies. With that said, I would like to welcome Dr. Zeidan.
Hi, good afternoon, everyone. I hope you can hear me quite well. And thanks for the foundation for this kind invite to share some of the ASH updates regarding MDS. We had a lot of interesting abstracts. This is a very difficult period, I think, for many patients and their families with the coronavirus epidemic, and I hope everybody is staying safe and following all these precautions that we all have to follow of social distancing and frequent hand washing and everything else to try to keep safe. Our patients have compromised immune systems, and definitely they are more at risk. And their families also should follow all these precautions very carefully to make sure our patients with MDS and hematologic malignancies are remaining in good shape. So I'm going to try to share my screen here, and I hope this works out well. Okay, I believe my screen is sharing okay. So these are my disclosures. As a busy clinical investigator, I work with a large number of pharmaceutical companies on different projects, and some of those abstracts presented are related to companies that I have done work with. So I'm just gonna start with some general introductions about MDS before we go into the discussion about the details of the abstracts. I'm gonna try to do my best to simplify things and I will use slides mostly as a backup way to kind of show some of the information visually, but we'll try to focus on things that are very relevant to our patients. So myelodysplastic syndromes are not only one condition, they are a group of conditions, and they are characterized by several common features, basically low blood counts and propensity for progression to more acute forms, such as acute myeloid leukemia. Myelodysplastic syndromes are cancers, so many patients don't realize that MDS is a form of cancer. And they generally, for patients who have more aggressive forms, can have significant complications, and it's important to realize that many of our patients are older. And this is why it's important not to neglect these type of diseases and think of them as just anemias or pre-leukemias. So the patient really has to understand the type of the MDS they have and to talk to their doctors carefully about the treatment options. So how do we diagnose MDS? The diagnosis of MDS is usually based on several important criteria. One is there are many things that could mimic MDS. Low blood counts can result from many conditions, from nutritional deficiencies, from medications, from other diseases. So it's very important to make sure that this is really MDS. And one of the more important ways to try to do that is by doing a bone marrow biopsy. I suspect most of the patients on this webinar who have a diagnosis of MDS have undergone a bone marrow biopsy, but this picture shows you how the procedure is done. And then we look under the microscope and do a number of studies to diagnose MDS. This is a busy slide, but the goal is to show you here how do we actually classify MDS. So MDS generally is classified as either lower risk or higher risk disease. And that's very important from a treatment point of view as well as from a risk stratification or a counseling point of view. So I'm showing you 4 of the most commonly used scores: the IPSS, the International Prognostic Scoring System, the IPSS-R, which is the revised version of the IPSS, the WHO-based scoring system, as well as the MD Anderson Prognostic Scoring System. There are a number of other scoring systems. All of these are in wide clinical use, but ultimately using any of those tools, what matters from a prognostic and treatment decision point is whether the patient has higher risk or lower risk MDS. You can see in this busy slide again that it's not only about these scores, but there are a number of other factors that go into our decision making for patients and how we can counsel them about different treatment options. For example, the age of the patients, the presence of other medical comorbidities, the presence of other cancers, their overall functional status are very important. And you can see also other clinical factors as well as histopathology, changes under the microscope, and genetic and cytogenetic alterations. All of those play a role. So many of you have heard about genetic mutation. So genetic mutation is basically an alternation in the DNA sequence. And there are 2 types of, or 2 big groups of mutations, because patients often sometimes can confuse what we call a germline mutation versus a somatic mutation. So a germline mutation is something that the patient was born with, and this is a minority of patients. Most of the mutations we talk about in MDS are somatic mutations, which means that they occur after birth and they develop during aging. And those are the ones that we often talk about for MDS. Few patients will have a germline mutation, but the vast majority they will develop with time in the form of somatic mutations. So what you can see here is that there is a large number of mutations. More than 90% of patients with MDS will have some kind of mutation. What you can see in the slide is that those mutations affect different pathways within the cell, what we call, for example, epigenetic pathways or splicing factors. And the size of those circles that you see correlates with the frequency of seeing those mutations. For example, the SF3B1, the DNMT3A, and TET2 are among the most common mutations. Those alterations are important because they help us understand the risk of progression of MDS, but also they are starting to serve as therapeutic targets, as we are going to show during the talk. One of the problems we have with MDS is that I showed you many mutations. However, most patients will have only one of those mutations, but most of those mutations are rare. For example, if you have heard of a disease called chronic myelocytic leukemia, CML, in this disease, almost all the patients will have the Philadelphia chromosome. While in MDS, as you can see, there's a very long tail, meaning that many patients will have some rare abnormalities. So this is one of the challenges that we have in the treatment of MDS, is that we don't have the same genetic alteration on everybody. Most patients will have different versions of those alterations. So how about the treatment of myelodysplastic syndromes? So there are different treatment options. Supportive care, which involves basically blood transfusions for patients who have anemia, platelet transfusions for patients who have low platelets, as well as stronger treatments for infections. All of those are applying to all patients. In addition to those, we decide on the treatment based on the severity of MDS. So for patients with lower risk, our goal is to improve the quality of life, to try to improve survival, but we don't currently have therapies that are proven to prolong overall survival in patients with lower risk MDS, and try to reduce the progression to acute myeloid leukemia, keep the patient out of the hospital, improve anemia, and minimize symptoms. While in patients with higher risk MDS, the disease is much more aggressive. It's almost closer to acute myeloid leukemia in some ways. So the goal of the therapy is really to prolong survival and alter the natural history of the disease with more aggressive interventions. So in the next 30 to 40 minutes, I will be basically sharing with you what I consider to be some of the more important presentations in myelodysplastic syndromes that were presented in the ASH meeting. However, I want to share those few points before we go into the abstracts. So there are many, many great abstracts that were presented. However, in this limited amount of time, I chose to present the abstracts that I thought are more relevant from a clinical point of view to patients, basically agents that are more in advanced testing and are potentially could come into the market into the next few years, rather than focusing on very early drugs or things that are more focused on the biology and the science, basically, rather than therapeutic abstracts. Doesn't mean that the other abstracts that I'm not presenting today are as great or important. And it's important also when you consider abstract that those are preliminary presentations, meaning that the actual papers have not been fully peer-reviewed. In many cases, the final papers have not been published, which means that some of the data could change over time or some updates will result. However, for the most part, the results would not change significantly from the original presentation. And the last thing is that a lot of what we will talk about applies to average patients. So each patient has individual factors that govern what are the most important clinical trial options for. So I think it's always very important that you talk to your doctor about how do these abstracts pertain to your care if you are thinking about enrolling in a clinical trial. So this is a general schema for lower risk MDS. So in the first part of the talk, I'm going to focus on lower risk MDS, and then I will move to the higher risk MDS abstracts. So lower risk MDS, as we discussed, basically, the goal is to try to minimize transfusions. One of the very common problems we have with MDS is anemia. And patients who have deletion 5q, some of you might be already on lenalidomide, which is an active oral agent for patients who have deletion 5q. For patients who don't have deletion 5q, the most common treatment in the US usually involve erythropoiesis stimulating agents, and that's a commonly used treatment, as well as in some situations the use of growth factor support such as GCSF. That would be the standard treatment, in addition to iron chelation, because blood transfusions can have, blood has iron in it. So when you give someone a lot of transfusion, they will build up iron in their body. And one of the things we consider in some patients with lower risk MDS is the use of medication to try to get rid of the iron. So this is, I would say, the more commonly used treatments for lower risk MDS. And I'm going to show you some of the new developments that are happening in the field. This is a summary slide from a recent publication that we published a couple of months ago, showing some of those active agents that I will be talking about that are in advanced clinical trial testing, such as luspatercept, imetelstat, roxadustat, and the IDH inhibitors. So this is the first abstract I wanted to talk to you about today. So these are the final results from a large cooperative group trial that have tested patients basically of using lenalidomide in combination with the erythropoiesis stimulating agent versus the erythropoiesis stimulating agent in patients, versus lenalidomide alone in patients who were unresponsive to erythropoiesis stimulating agents or unlikely to respond. And again, I don't think the details of the data is of a lot of interest to the individual patient, aside from knowing that it sounds like in some patients, when you add lenalidomide to the injection to the erythropoiesis stimulating agent, the chance of major erythroid response, which means improvement in anemia, appears to be higher for patients with the combination. So from a clinical point of view, that implies that for patients who are not responsive to ESAs or unlikely to respond, what we have considered in many of those patients is the use of lenalidomide as a single agent. However, the chance of response has not been particularly great. So in this study, they've shown that lenalidomide in combination with the erythropoiesis stimulating agents seem to be better than lenalidomide alone. So this is one consideration to think about for patients after the erythropoiesis stimulating agents stop working. So the other, I think, interesting development from this ASH, and this has been presented already a couple of times, and actually the paper has been published in the New England Journal of Medicine using this agent called luspatercept. So luspatercept basically is an agent that is given IV, so this is intravenous, and it works on a pathway called transforming growth factor pathway. Activation of this pathway has been shown to lead to anemia and is part of why patients with MDS have anemia. So this is what we call a ligand trap. You can think of it as basically as a way to trap those proteins, the transforming growth factor ligands that lead to the anemia. And the use of this agent has been already shown to improve anemia in patients with lower risk MDS who have a type of MDS called ring sideroblast. So this is accumulation of iron around the nucleus in patients with MDS, and those patients who have lower risk seem to respond to this drug. So what was shown in ASH 2018, and this was subsequently published in the New England Journal of Medicine, that the use of this agent compared to placebo, basically compared to not giving any active agent, lead to significant improvement in transfusion independence, meaning that the patient stops requiring transfusions for 8 weeks or more. The number was 38% compared to 13%. And what was presented in this year, in the American Society of Hematology meeting, is a longer follow-up of those results. And those data have shown that many patients will have some period of transfusion independence. So the number goes up to 48% compared to 16% for patients who are receiving placebo. And now there is a frontline study called the COMMANDS trial, in which patients with MDS are being randomized to receive luspatercept versus ESA as a first agent. So not after ESA failure, like in this study, the Middle East. This is as a frontline therapy. So luspatercept is actually currently in front of the FDA being considered for approval in the setting of patients who have ring sideroblasts with lower risk MDS. So another agent that has been presented in the American Society of Medicine, American Society of Hematology meeting is the roxadustat. So this is another agent that stabilizes a pathway called the hypoxia-inducible factor alpha, or HIF-alpha, and this has been shown to improve anemia. This agent has actually also been shown to work in patients who have anemia related to chronic renal impairment, and it has been of interest to study it in MDS. So a small study, it's a small number of patients, 24 patients in a phase 2 study, has been presented in the meeting, and it showed basically that patients, around 38% of patients achieved transfusion independence for 8 weeks or more. So again, showing proof on principle that this agent does seem to work. And there are ongoing studies to look at this agent basically in a phase 3 setting for patients with lower risk MDS who are having anemia. Another agent that is also in phase 3 testing is called imetelstat. So this is data that was presented in ASH in 2018, and there was a subsequent update in ASH 2019. But the data is along the same lines, basically showing transfusion independence for 8 weeks or more, which is a commonly used endpoint for lower risk MDS in around 37% of patients with MDS. So this is another agent that is currently in clinical trials. So for many of our audience, or people with MDS who are not responding to erythropoiesis stimulating agents, all of those agents are in clinical trials: luspatercept, imetelstat, and roxadustat, and they could be good options to try to go in one of those clinical trials if you have a clinical trial that is close to where you are. So currently, basically, the most commonly or the available agents currently for patients with anemia with lower risk MDS are lenalidomide. We talked about that, but also immunosuppression with immune suppressive agents, as well as hypomethylating agents. All of those are being used. Hypomethylating agents we'll talk about more because they are more commonly used in higher risk, more aggressive forms of MDS. But sometimes in patients with lower risk MDS who have anemia that does not respond to anything else, sometimes we use it. And you can see the rates of response here are somewhat variable. And those are the investigational agents that we just discussed in the earlier slides. How about patients who have thrombocytopenia? So thrombocytopenia means low platelets. Platelets are the cells that are made in the bone marrow that protect someone from bleeding. So when you have very low platelets, the patients are at risk of bleeding. Some patients with MDS have low platelets as the main problem, and they are at risk of bleeding. While we do platelet transfusions, this is a temporary solution. So there are a number of agents that are also have been tested and are undergoing testing in patients with low platelets. And one of them is eltrombopag. This is an agent, an oral agent that's already approved for aplastic anemia. And there has been some studies, there are ongoing studies looking at the use of this agent in patients with MDS and who have lower risk form of MDS with severe thrombocytopenia. And it does seem that among those patients, there's a significant increase in platelet count and reduction in bleeding episodes. This agent is still not approved for patients with MDS by the FDA, but it's available for aplastic anemia. And we have used it off-label in some patients who have very severe thrombocytopenia that's not responding to other agents. How about patients with higher risk MDS? So we are switching gear now to higher risk MDS, which is the more aggressive form of MDS. That's a form that in many patients can limit survival significantly. So we try to go for more aggressive treatments, which would include allogenic bone marrow transplantation, or commonly referred to as HCT. This is a commonly used methodology for acute leukemia. In MDS, because the average age of patients with MDS is around mid-70s, 76-year-old, allogenic bone marrow transplantation is an aggressive intervention. You can think of it as a major surgery. So many older patients will not be candidates for that. However, with improvement in supportive care and better typing of donors to find matches for patients, more and more patients are being transplanted. So one of the common things I hear from patients when I see them in the clinic, I get a lot of referrals from the community, is that sometimes their doctor might have thought they are too old for transplant because they are in their late 60s. We can transplant patients until they are in their early to mid 70s, as long as they are in pretty good shape. So at the very least, I think it's reasonable to have a discussion about it, even if your doctor, your community doctor might not necessarily think you are a great candidate for it, but I do think that it's something that you want to think about, because the field is moving forward very quickly. So the other agents that we talked about are hypomethylating agents, and those have been the backbones. Those are two main drugs that are approved in the US, azacitidine and decitabine. Both of those are given by injections. So azacitidine can be given under the skin or in the vein, what we call subcutaneous or intravenous, while decitabine is given as an infusion through the vein. So those are given usually 5 to 7 days each month. So they require coming to the clinic for 5 to 7 days, and they are the only treatments that are approved for patients who have higher risk or more aggressive form of MDS. Sometimes we do these as a bridge, as a way to get the patient to transplant while we are sorting out all the logistics of going to transplant. So there are a large number of agents that are currently being tested in clinical trials for patients with high risk MDS. This is a slide from a manuscript that we currently have under review, showing some of those agents and the pathways that they work on. Again, this is a busy slide, but the idea is to show you that there are many agents that are in clinical testing, such as venetoclax, APR-246, pivonedistat, the anti-TIM3 agent, MPG3, this is a typo actually, 453, and anti-CD47 IDH inhibitors, as well as immune checkpoint inhibitors, and some oral versions of hypomethylating agents and rigosertib. So I'm going to cover some of those abstracts in the next few slides. So APR-246, some of you might have heard about this agent. So this is an agent that is being tested for a specific subset of patients with MDS, called patients who have TP53 mutation. So this is an alteration. TP53 is the most commonly altered gene in cancer. It accounts for almost half of all cancers. And when it's mutated, it generally indicates that the disease is more aggressive and less likely to respond to conventional treatment or even to bone marrow transplant. It occurs in around 10 to 15% of patients with MDS, and it's more commonly seen in patients who have what we call therapy-related. So patients, for example, who had breast cancer or prostate cancer and received chemotherapy, some of those patients are at risk of development of myelodysplastic syndromes as well as acute leukemia. And this is one of the agents that specifically targets this alteration. So the way it works is basically when you have a mutation in TP53, many of those mutations leads to what we call abnormal folding. So the protein becomes dysfunctional. What this drug, which is an infusion by the vein, do is reactivates the TP53 and leads to reactivation of the enzyme, leading to subsequent cancer cell cycle arrest and death of the cancer cell. So this is the principle in which this drug has been developed, and it has been combined with azacitidine. So most of the trials that I'm going to show you, because we know azacitidine or decitabine are the two agents that are commonly used and approved for MDS, most of those clinical trials usually add whatever agent is being tested. For example, here the APR-246 to azacitidine. So in this trial, presented in the American Society of Hematology meeting, this trial has been presented already a couple of times in previous meetings, and these are updated results. So what you can see here is that many patients are responding. So the response rate overall has been around 53%. But this trial had patients who had AML and MDS. Again, all of those patients had this TP53 mutation. And the response rate in patients with MDS among patients who are evaluable, again, small numbers. And I think this is why we have to be always cautious with these results, because only 33 patients, for example, were treated here in the MDS arm. The response rate was 61%. So promising response rate, because as I mentioned briefly earlier, is with azacitidine alone, historically, the response rate is somewhere in the range of 20% or less for a complete response. So we think of this number as indicating good activity, and this agent is currently in a phase 3 trial in which patients are receiving APR-246 with azacitidine versus the standard treatment, which is azacitidine, for patients who have a TP53 mutation. About glasdegib. So glasdegib is another agent. This is an oral agent. It works on a pathway called the smoothen or the hedgehog pathway. So this is an oral agent that is actually already approved for patients with acute myeloid leukemia. For older patients who have acute myeloid leukemia, in a combination with a drug called low-dose cytarabine. And in this trial that I also was one of the authors on this trial, we tested the use of glasdegib for patients both with MDS as well as AML in combination with azacitidine. I mentioned the drug is approved for patients with with AML, but it's in combination with low-dose cytarabine. So in this trial, we wanted to test the combination with azacitidine because azacitidine is a much more commonly used agent in the US. Low-dose cytarabine has to be given for 10 days in a row, which is, in many protocols has to be given twice a day, which can be quite challenging because it would involve home administration. So there was a lot of interest in trying to study that in a setting in which it's combined with azacitidine. And what you can see here is that the response rate, there were some responses, as you can see here, around 33% response rate between complete response and partial response. And this is in combination with azacitidine. So this is one of the agents that's an oral agent. Again, this is not approved for MDS, but it's currently under being studied. And these are the survival data from this trial. How about the other agents? So we have another oral drug called venetoclax. So there were two trials that were presented for patients with MDS in the American Society of Hematology. I presented this trial on behalf of my colleagues that you can see here for venetoclax, an oral agent in combination with azacitidine. But this is for patients who have relapsed or refractory MDS. So this is not as a frontline treatment. This is after failure of those hypomethylating agents already. This is a complex slide just showing the dose escalation. So we generally, each time we do a clinical trial, we start with a lower dose of the agent to try to minimize the chance of toxicity. And as we show that this trial is safe, we go up to the higher dose. So this is what happened in this trial. We used 100 milligram dose of venetoclax, which is a small dose for this type of disease. And we went up all the way to 400 when it's combined with azacitidine. We had another arm in the trial that used venetoclax, the oral pill, as a single agent. However, the activity was not particularly great with this arm alone. When you are looking at venetoclax as a monotherapy, as a single agent. What we've shown that when you combine it, the overall response rate is around 40%. Again, this you have to remember that this is in a setting of hypomethylating agent failure, which is a setting that is very difficult to treat, and there are no available options for therapy for that setting. So those results were encouraging. However, like the other trials, it's a small sample size and early follow-up. So we need to see the activity over a longer time to make, and hopefully more studies in bigger sample size, more patients to get a good sense about the activity of this agent. Another study studying the same agent, venetoclax, in combination with azacitidine, but this study was done in patients at the front line as the first treatment. This was presented by Dr. Wei and his colleagues that you see listed here. And they used a similar paradigm in which venetoclax was started at a smaller dose and went up to higher doses. And what you can see here is that azacitidine was given in the standard way, which is 7 days in a row intravenously or under the skin. Usually under the skin is subcutaneous is a common way of giving azacitidine. In addition to venetoclax, but the venetoclax was given for 14 days. Remember, venetoclax is an oral agent, so you can take it at home. For azacitidine, you have to come to the clinic for 7 days in a row. And what the authors have shown is that the overall response rate was around 77%, what you can see here in this graph. Complete response rate was around 39%. Those are encouraging numbers because, as we mentioned earlier, the response rate with azacitidine alone is generally in the range of 20%. Of course, this is what we call a single arm study, so meaning that we did not compare directly in the same study in a randomized fashion to azacitidine alone. So you cannot make definitive conclusions from that. And the sample size is small and the follow-up is limited. So for all of those factors, I think those are interesting results, but we need more data basically so that we fully understand how venetoclax could affect the care of patients with MDS. Venetoclax is already actually approved for patients with acute myeloid leukemia in combination with azacitidine, decitabine, or low-dose cytarabine. So it's already available in the market, and some physicians have been using it already off-label use for patients with MDS. I've definitely seen a number of patients in my clinic who are receiving venetoclax by their doctors, and that's largely because for patients who are not candidates for allogeneic bone marrow transplantation, sometimes the options can be limited in terms of what you can give the patient. So some people use it when they have no access to a clinical trial. And this is our overall survival data, but the follow-up is limited, as I mentioned. So we need longer time to fully understand the impact on survival. Another agent that was presenting in the American Society of Hematology meeting, and also I was involved in this trial, the Ascertain trial, looked at an oral version of decitabine. So this is a trial that basically looked at what we call the pharmacokinetics. So we are looking at the level in the blood, basically, of this agent, which is an oral version of hypomethylating agent. It's called Aztec 727. As I mentioned, one of the problems with azacitidine or decitabine is that they are given in the clinic intravenously or under the skin, meaning that the patient has to come 7 days or 5 days in a row every month, which for patients who are on those therapies, generally we continue as long as they are responding. So some patients can be on those drugs for 3-4 years. And it can be quite disruptive for many patients to come 7 days in a month to receive those agents. So the interest here was to try to see if this oral agent could replace the intravenous decitabine so we can avoid having to bring the patients as frequently to the clinic. And the idea is that this is decitabine combined with another agent called sidazoridine. So this agent prevents an enzyme that digests decitabine, which allows it to go to the blood without being consumed in the gut or the liver and allow it to be taken by mouth. So the agent was basically given, the patients were randomized to receive the IV version versus the oral version. And as I mentioned, the primary endpoint was what we call biopharmacokinetic equivalence, meaning that the blood levels of both agents would be very similar. And this primary endpoint was achieved, meaning that from a pharmacokinetic point of view, the drugs, the oral and the IV version seem to be equivalent. And therefore, this potentially could replace the IV decitabine for patients with MDS. So this agent, the efficacy, the preliminary efficacy data, again, this trial was not designed to look specifically at the efficacy. The primary endpoint was to look at the blood levels, but the efficacy seems somewhat similar. Again, we have to have longer data to fully understand the impact, but the data has been encouraging. And this agent is also in front of the FDA currently being considered for approval, and we should be hearing about that in the near future in terms of what the FDA decides on this data and whether they will allow it to be used in the market. How about another oral agent, the IDH1 and 2 inhibitors? IDH, isocitrate dehydrogenase. So this is an enzyme that is abnormal in patients with AML. Up to 20% of patients will have an abnormal mutation in IDH1 or IDH2. In patients with MDS, the frequency is much less. So it's, in my experience, is somewhere around 5%. However, in patients who do have the mutation, the use of those agents, so enasidenib is the IDH2 inhibitor, ivosidenib is the IDH1 inhibitor. Both are oral agents, and they have shown a good activity. CR, the complete response rate, for example, you could see some patients have achieved complete response, partial response. So it does seem to have good activity. There was another agent basically that also was tested called FT2102. So this agent is also an IDH1 inhibitor. So this agent is still not approved in the market. The ivosidenib, the IDH1 inhibitor, is already approved in the market, but for acute myeloid leukemia in older patients, either patients who are refractory, meaning that they did not respond to the standard treatment, or older patients who cannot tolerate strong treatment, but it's not approved for MDS. However, again, because sometimes patients have limited activity or limited accessibility to clinical trials, if the patient with MDS has not responded to standard treatments and they do not have access to a clinical trial or bone marrow transplant, and they have an IDH1 or IDH2 mutation, as I mentioned, the problem is that those are quite rare in patients with MDS. Using those those agents could be considered in some of those patients. The FT2102 has also shown activity, but this agent is not on the market, it's still being studied. It's also an oral agent. In the last few minutes, I'm gonna cover a group of drug called immune checkpoint inhibitors. You probably have heard about some of those in other cancers because they have shown great activity in patients who have lung cancer or melanoma. So the idea is that the development of cancer in a lot of the patients is related to the immune system stopping to recognize the cancer, and that allows the cancer to proliferate. So those agents, the immune checkpoint inhibitors, the idea is that you are removing the brakes from the immune system so that it gets activated against the cancer. So there are a large number of those agents. Again, complex slide, but shows you how many agents that are being currently tested. Some of those agents are being tested in myeloid malignancies, in acute myeloid leukemia and MDS. I presented one of the large randomized studies. This is actually the only randomized study testing one of those immune checkpoint inhibitors. It's a drug called durvalumab, which is an anti-PD-L1 in patients both with MDS and AML. And patients were randomized to receive azacitidine alone or azacitidine with the durvalumab. Unfortunately, the results of this trial was negative, meaning that there was no improvement in the response rate with the combination. However, this durvalumab is an agent against PD-L1. So it's one type of an immune checkpoint inhibitor. However, there are a number of other agents that are being tested currently. For example, this is another trial that I'm currently leading, in which pembrolizumab, which is an anti-PD-1 inhibitor, is being tested in combination with another drug called entinostat for patients with MDS after hypomethylating agents. This is an international study being conducted within the Early Therapeutic Clinical Trial Network. This is another agent called TIM3, or another molecule called TIM3. And this is also an immune checkpoint inhibitor, but it's also expressed in some of the leukemia cells. And there is data, this is from the abstract that was presented in the American Society of Hematology by Dr. Borati and her colleagues. What they have shown is that the combination of this agent, the anti-TIM3, MPG453, with decitabine has led to activity with an overall response rate of around 57%, and around 26% of patients had complete response. Again, this is a small number of patients, 19 patients, so it's difficult to make strong conclusions based on that. However, some patients did have durable responses, and based on that, a randomized study called Stimulus MDS1, in which patients are being randomized to receive hypomethylating agent, whether it's decitabine or azacitidine, up to the physician choice, plus minus the MPG453. So this is, I think, an important trial because it would let us know if this combination is indeed active or not. And this trial is currently ongoing in several centers in the US and Europe. Another interesting immune checkpoint inhibitor are agents that work against a protein called CD47. So this CD47 is what we call don't eat me signal. Many of the normal cells of the body will have the CD47 so that it tells the macrophages, which I tell patients, think of them as Pac-Man. You remember the Pac-Man, so the cell that engulfs the bacteria. So this agent tells, this protein CD47 tells the macrophages that it's a normal cell. So what cancer cells does, and that includes leukemia cells, they increase the expression of this CD47 to try to fool the macrophages and the immune system to think it's a normal cell, and it doesn't eat it. And this pathway has been jacked by the cancer cells to evade being killed by the immune system. So the same idea here is that when you are using an antibody that blocks the CD47, then you are reactivating those macrophages to eat the cancer cells and lead to improvement in patient outcomes. So this is the theoretical consideration of using this agent. There are several of those agents. I presented one of them called CC9002 agent in the American Society of Hematology. This was a negative study, so this agent did not work. However, another agent called magrolimab was shown to have good data. So in those patients, again, small number of patients, 24 patients with MDS and 22 patients with AML, the overall response rate was around 90% for MDS patients, 50% of complete remission. So interesting early data. Again, small number of patients. We need longer follow-up. We need, randomized trials to show that this is actually a real effect and active. But I think the data definitely seems encouraging. Pivonidistat is another agent that is being also studied for patients with MDS, and there are ongoing phase 2 and phase 3 studies looking at that. And there are a large number of other agents basically that are being tested. For the sake of time, again, I'm not going to go over these because I want to make sure I leave some time for questions. This slide shows you some of the genetic alterations we talked about and how those could be used to direct treatment decisions. So I think it's always important to talk to your doctor about what's your prognostic score and what mutations do you have, because those can help in also making decisions about transplant, but also making decisions about clinical trials that you can use. Because as you can see in this slide, there are a large number of clinical trials that are ongoing. And I always tell my patients, and as you can see in this publication, that I always think the best treatment for any patient with MDS, whether it's higher risk, lower risk, untreated, or relapsed patient, the best treatment is always a clinical trial, because despite improvements in outcomes, I think there's still a significant need to improve the outcomes of our patients even more. And these are my disclosures, and I would like to thank all the organizations that helped my research, including the Aplastic Anemia and MDS International Foundation and the Leukemia and Lymphoma Society and Conquer Cancer Foundation. And I will be happy to take any questions.
Thank you so much, Dr. Zeidan. We do have a few questions. Our first question comes from a patient who is diagnosed with MDS 5q deletion. They just started Revlimid. How long will it take for the neutrophil numbers to start to rise?
For which number, sorry? For the neutrophil?
Neutrophil, yes, sir.
Okay, that's a very good question. So in patients who have deletion 5q, most of the time when you are using lenalidomide, the goal is to actually improve anemia. So generally, lenalidomide by itself does not, in most patients, will improve the neutrophils. What usually happens actually with lenalidomide often is that the neutrophils might drop a little bit. So usually we have to monitor the neutrophils and make sure they don't drop a lot, because this can cause infections. But for the anemia, to improve the anemia itself, most of the time, the use of lenalidomide can take 3 to 4 months. So generally, I tell my patients when I start lenalidomide is that these therapies, all of the MDS therapies that I just showed you, the erythropoiesis-stimulating agents, lenalidomide, hypomethylating agents, they are slow to act. They can take several months, 3 to 4 months. So as long as the patient is doing well and they're not having significant problems, I usually continue for 4 months before deciding whether lenalidomide worked or not.
Thank you. Our next question, if you have lower risk MDS and are transfusion dependent, will we not be able to get luspatercept when approved for MDS if we do not have ring sideroblast?
That's an excellent question, and I think some of it is, so the large trial, the Medalist trial, the phase 3 trial, basically looked only at patients who had ring sideroblast. So depending on what comes on the FDA label, basically, the issue will be whether you would be able to get the drug or not. So, what happens is that, sometimes if the label is limited to patients who have ring sideroblast, then your physician will have to kind of make the case to your insurance that they think you might benefit. Because there is some data, it's not a lot of data, but there is the phase 2 data from the PACE trial in which luspatercept has been tested in patients who did not have ring sideroblast. So the response rate was not as high, but some patients did respond who did not have ring sideroblast. As I mentioned, there is the ongoing COMMANDS trial, which is a frontline trial. So for patients who have not received ESAs, this could be another way to try to, to get luspatercept. But if the patient does not have ring sideroblast, and FDA approval comes only for patients with ring sideroblast, then I think it becomes a discussion between the provider and the patient and the insurance provider about whether they would cover the agent or not. But from a safety point of view, I don't see any specific reason why it should not be tried.
Thank you. Our next question, can you have MDS with a non-active TP53 mutation?
Correct. So TP53 mutations basically can occur in around, and the average number is around 10 to 15% of patients. So most patients with MDS will not have a TP53 mutation. Now, I think what we are starting to realize that not all TP53 mutations are the same. So how much of the TP53 mutation you have is something we call variable allele frequency, and what other mutations do you have, the specific type of the TP53 mutation. All of those seem to make a difference. So it's not only whether you have a TP53 mutation or not. Generally, not having a TP53 mutation is definitely better than having one, but not all the TP53 mutations are necessarily bad. It depends on those factors that I just mentioned.
Thank you. Is venetoclax contraindicated in patients who have cardiac rhythm problems or have a history of cardiac rhythm problems?
Actually, I don't specifically know this question. I have to look into it, but the concern basically in some patients is what we call the QTC interval. So patients who go on venetoclax, they have to be monitored for their heart issues. You should talk to their cardiologist and things like that. But it's always what we call a risk-benefit situation, meaning that depending on what are the options that you have and what are the risks of getting the drug, can it be monitored, not monitored? All of those, I think, have to be taken into consideration and making the decision together with the patient and their cardiologist about the risks and benefits of using the drug.
Thank you. Can you touch on any promising CAR T therapies for MDS and AML?
A great question. So I mentioned one way in which the immune system is being targeted using the immune checkpoint inhibitors. However, there are a large number of other agents that are being tested, including what we call bispecific T cells and CAR T cells. So CAR T cells have shown great results in patients with acute lymphoblastic leukemia and some forms of lymphomas. In myeloid malignancies, the challenge has been is that those CAR T cells can lead to significant depletion of the neutrophils, and that can be quite problematic. So this has impeded the development. However, there's several techniques that are trying to overcome this issue, and a number of those agents are actually being studied in clinical trials to look into that.
Thank you. For older patients with spliceosome mutations, but not yet transfusion dependent, would it be recommended to go to a bone marrow transplant?
So going to a bone marrow transplant basically is a complex decision. It doesn't only depend on having a mutation, it involves multiple other factors. So what is the age of the patient? How they are medically? Is there a donor? Are the patient basically accepting the risks that come with the transplant? So there are multiple number of factors that go into this calculation, not only a specific mutation or alteration. So it depends on an overall assessment and understanding of the risks and benefits of the situation.
Thank you. Is Promacta being studied for low platelets in MDS or AML patients?
Correct. So the Promacta, eltrombopag, I showed one slide on that, is being studied in patients with lower risk MDS. In patients with AML and higher risk MDS, there has been a concern that eltrombopag might worsen the disease and increase the number of the blasts. So there has been always this concern. In patients with lower risk, we use it generally as I said, a last resort, and we often make sure we counsel the patient and monitor the blood very carefully, and it's an off-label use really. There are some studies, for example, when eltrombopag was combined with azacitidine, the trial was negative. It actually worsened the outcomes. So there are certain situations, but this is why clinical trials are important. So I would not use it in combination with azacitidine. If I use it, it's usually used alone in the absence of other options, basically.
Thank you. How durable are the anti-CD47 antibody treatments?
So the trial that I mentioned, like, is still a small number of patients and still early on. And this is why I was saying that it's very difficult to make, judgments about early results, because some of those trials, basically, we've seen that in other trials where you see a high response rate and the response might not necessarily be durable. So this is why I always, encourage caution when you look at the results of any agent, not only this agent, but with any agent, meaning that you have a long follow-ups. You need at least a year to 2 years of follow-up to see that not only that the responses are frequent, but also the responses are durable. So I think it's too early at this point, and we have to continue to see the follow-up from that study as more data get presented in meetings.
Thank you. Did the trial you mentioned with the CD47 antibody have an arm which was used with the antibody alone?
I don't believe so. I think the combination was that the treatment. I can't recall if in this particular trial, but I think the antibody alone has been used previously, and it doesn't work particularly well as a single agent. I think the data was in a small number of patients, but I can't recall it was within the same trial. The more exciting data was in combination, basically, with azacitidine.
Thank you. In regards to luspatercept, for patients who may currently be using Procrit or Aranesp, will they be eligible to use luspatercept, and would there need to be some type of switching or moving to luspatercept?
Yeah, so that's a good question. So basically, the way the Medalist trial was done is that the patients would have either received those agents, the Aranesp or Procrit, the ESAs, and they stopped working, or that the patient was extremely unlikely to benefit from those agents because their erythropoietin level was too high. So in those situations, basically, and if the patient has ring sideroblast, if luspatercept becomes available, then it can be used in this situation. So it's not usually used in combination with those agents. So what would be happening, in a standard setting is that those agents would be stopped, and then luspatercept would be started as a single agent. The use of the combination is an interesting question. This is something that investigators are looking into, whether combining those agents would increase the response, but we don't have data on that.
Thank you. And in the trial with luspatercept, was there data collected about patients who were transfusion dependent, and were they still developing iron overload while using luspatercept?
Yeah, so there has been some presentations on that, and I think the idea is that if you improve transfusion dependence, meaning that patients stop needing transfusions, and we know most of the iron that MDS patients get is from the blood transfusions, that would lead to some improvement. But of course, again, we need longer follow-up data on that issue.
Thank you. And thank you very much, Dr. Zeidan. That's all the questions we have for today, for sharing your time and expertise with us. If you would like to watch this webinar again at a later time, it will be available on our website for view within 2 to 3 business days. You will be receiving an email to complete a survey. Please take a few minutes to complete this brief survey. Your responses help us plan future webinars and make sure we are meeting your needs. By registering for this webinar today, you will receive email announcements from the Foundation regarding upcoming webinars and any new information that is posted on our website. If we were not able to answer your question today, you can send it to us at any time in 3 ways. 1, send an email to help@aamds.org. 2, call the Foundation helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The Foundation Medical Advisory Board and our team are here to help you and your family as we have done for the past 36 years. This concludes today's program. Julie.
So I think that went quite well.
I think she's gone. Thank you, Dr. Zeidan. It was wonderful.
Yeah.
Thank you.
Always a challenge with the scientific slides, but I think it sounded like people got the gist of things. Yeah.
Absolutely. Thank you so much. It was great. And I hope you and everyone stays safe.
Sure. So some, in the past, like people have emailed questions. I'm happy to kind of handle any email questions that you get by emails later.
Perfect.
Sure. Thank you.
Thank you. Take care now. Bye-bye.
Bye-bye.